If a patient is, deemed to be a good candidate for this operation and they're going to get the operation done, we'll see the patient in the preoperative holding area. They'll stand up and we'll mark them out with a skin pencil and make our planned incision marks, the planned incision around the belly button, and they then go to the operating room, they go to sleep, and once they're asleep, an incision is then made. I generally start around the belly button and then move down below and remove or make an incision at the lower part of the panty line, very low. We remove or make the incision from basically hip bone to hip bone and then go up under this, lifting the skin and subcutaneous tissues or the skin and the fat off of the abdomen, carefully working around the belly button to leave it undisturbed, and then we carry that all the way up to the rib cage or the xiphoid process. We then take out a suture and suture those two pieces of muscle back together. Why do we do that? That helps narrow the patient's abdomen, kind of restore some of the hourglass shape, and also flattens the abdomen as opposed to having a bulge in the abdomen. If you just cut out some skin and subcutaneous tissue and brought it down, typically what will happen is they'll still have a bulge. The fascial tissue between them is separated and it'll actually bulge because the strength is in those muscles, or the muscles and the fascia combined. And when you bring those back, that flattens the abdomen a lot better, or makes it a much nicer contour. So we suture those muscles down, and after that's done, we remove the skin that we don't want in and then sew the wound closed. But prior to doing that, we set the abdominal the umbilicus rather, in the proper position. A few other little fine points to make that look better and to make the belly button kind of sink in a little bit so that you can't see the scar as well. I won't go into those details, but then we sew the wound closed. In very rare cases, we can do it without drains, but most of the time the patient has a drain for a short period of time. The drains will stay about a week. We generally see the patient within a few days of the procedure to make sure they're doing well. Typically, we'll have the drains taken out about anywhere from 7 to 10 days roughly. After that, the patient starts to feel much, much better. That first week is pretty rough. They definitely need to take that off of work. That first week. I would prefer if they took 2, perhaps even 3 weeks off of work, just in case they have any little hiccups afterwards. And then the most important thing after that is slowly getting back into normal activity. If a patient is very aggressive in getting back to normal activity, what can happen is the flap or the skin and the muscle underneath will rub against each other, and you can get fluid buildup in there, and that becomes a problem. We don't want that happening. So the patient needs to make sure that even when they start feeling better, not to be too aggressive in returning to normal activities.